he has a passion for swallowing when nobody was talking about swallowing. Now swallowing is come up to the stage where people are talking about pathologies and the treatment protocols and everything. So we are going to have a specialist in the pathology. Dr. Nilanjan is a good friend of mine as well. So he is going to talk about the pathologies. And Dr. Suresh Kumar, you stay back. You will be involved in the panel discussion also. Thank you.
Thank you very much, Thiru and team. Yeah, thank you very much, Thiru and team, for the invite and as well as for being such kind hosts. So, swallowing pathology in pediatrics or pediatric dysphagia. Now, we know that dysphagia is any impairment of swallowing that compromises the safety, efficiency, or adequacy of nutritional or liquid intake. Swallowing disorders put an incalculable burden not only on the child suffering from it but also on the family associated with it. Now, at the outset, it's important to put a distinction between feeding disorders and swallowing disorders. Now, pediatric feeding disorders as defined by Godey is impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skill and or psychosocial dysfunction. Now, for example, difficulty in drinking from a cup, difficulty in latching onto a breast or sucking, difficulty in taking from a spoon or keeping the food in the mouth. These are all examples of feeding disorders. On the other hand, swallowing disorders or dysphagia are defined as abnormalities in any of the 4 phases of swallowing. Now, having said that, there's a certain degree of overlap that exists, especially in the oral phase of swallowing, which has a lot of overlap with feeding disorders. And so in 2007, the American Speech and Hearing Association coined an inclusive term called feeding and swallowing disorders. Now, just to give a perspective of the burden of the problem, there's a study by Bhattacharya which has shown that 0.9% of all children tend to have some form of feeding or swallowing disorder. Again, different studies, depending on what you quote, have shown that 30 to 80% of children with neurodevelopmental disorders have some form of dysphagia. And of course, airway anomalies, problems with the airway, laryngeal clefts, laryngomalacia, and unilateral vocal cord palsies have a very high proportion of silent aspiration. Now, there's a subset of pediatric population who are at a higher risk of having dysphagia. Preterms require a little elaboration. I'll just come to that in a minute. Neurological disorders like spinal muscular atrophy, Duchenne's, all of these can cause a lot of dysphagia. Cerebral palsy requires special mention because different studies have shown that from 19 to 99% of CP children tend to have some form of dysphagia. Again, children with respiratory and cardiac issues, now congenital heart disease children and children with respiratory distress syndromes. You see, these children first of all have a delay in the maturation of the various reflexes associated with swallowing. 2, because of their respiratory status, they are unable to hold the breath long enough to cause an effective swallow. And finally, prolonged swallowing or swallowing for a prolonged duration is very difficult in children with cardiac disorders. So cardiac and respiratory disorder children tend to have a lot of dysphagia. Again, traumatic brain injuries or brain infections, which especially affecting the brainstem, can cause dysphagia. Gastrointestinal disorders like gastroesophageal reflux, eosinophilic esophagitis, these have very high proportion of dysphagia. Airway malformations we have been seeing since the last 2 days, clefts. Congenital abnormalities like the Pierre-Robin sequence, a cleft palate, all of these contributing to dysphagia. Now, while the clinical features associated with feeding or swallowing disorders are quite obvious, as I went through studies, this was just this Korean study that I got, which has demarcated the first 6, which are marked in red, as the clinical manifestations of children suffering from dysphagia, with choking being the most common, coughing and choking being the most common, and then the rest of them. Additionally, it's quite obvious that children with some form of dysphagia will have refusal to feed, pocketing, recurrent respiratory tract infections, wet voice, throwing out the food. So these are all part of the feeding and swallowing disorder complex. Now, these are some of the reflexes which are pertinent to a swallow, and these are present since birth. Eventually, after a certain point of time, 6 months or even later, most of these reflexes disappear other than the swallowing and gag reflex, which persist on throughout life. Now, there's something interesting about the gag reflex. You see, in very young children, infants, neonates, the gag reflex is present at the anterior tongue. So this is of course protective so that they don't take in anything hazardous, take in anything solid. This starts moving posteriorly, and by the age of 6 or 7 months, it goes to the posterior 1/4 of the tongue. Now, in children who have neurodevelopmental disorders, the issue is that this does not move behind. So what happens is, even in older children, especially when they are weaning, they start having the gag when you give them some food anteriorly. So that is one of the issues. Now this is, as I was saying, about preterms. So pharyngeal swallow starts in around 10 to 12 weeks of gestational age. The suck, swallow, breathe, which is the mainstay of a good swallow, an efficient swallow. Suck, swallow, breathe reflex, or the entire complex, develops around the 32 or 34 weeks of postmenstrual age, and it keeps on maturing after that. Now, with an increasing number of infants surviving, preterm infants surviving rather, and some deliveries occurring before the age of 34 weeks, this reflex has not matured enough. The problem is, with an inefficient suck, swallow, breathe reflex, you have a lot of feeding disorders or swallowing disorders. Now, ideally speaking, the suck swallow should be 1:1, basically meaning that with one suck there should be one swallow, and if you take in the breathe component, it should be 2:1, that is 2 sucks, 2 swallow, and 1 breathe. Again, a lot of these preterm children tend to have some respiratory disorders. I have already mentioned that the suck, swallow, breathe reflexes develop a little later in these children. Additionally, these children cannot muster up enough breath to keep themselves, the apneic phase of swallowing. What one must also know is that preterm infants have a very high rate of breathing, 40 to 60 breaths per minute, which effectively is around 1 to 1.5 breaths per second. Now, in an effective swallow, the breath holding time would be anywhere from 0.35 seconds to 0.75 seconds. Now you realize that is so much time which the child cannot breathe. And that is where the problem starts arising, especially in children with RDS, respiratory distress syndromes. So again, in preterm infants, what happens is the integration of the respiratory function with the suck and swallow can be very variable, can occur quite late. Now what happens at a central level is this, that the suck, the swallow, and the breathe, all these three functions have different central process generators located in the pons and medulla. Now the function of these central process generators is to synchronize and functional maturation of the set of muscles associated with it. But then each of these generators sometimes develop at a different rate, and because of which oral feeding becomes a problem. So how do we go about evaluating these children? The non-instrumental evaluation, the first thing is to elicit a good history, the time taken to feed the child. Now any feeding, any meal time which takes more than 30 minutes is considered pathological. So it needs to be investigated. Is the child's dependence on others for feeding appropriate for the age? That is a question that needs to be answered. Is the child feeding exclusively orally? And if it is, then is the feed appropriate for the age, the amount? Again, the child's response to certain textures, certain consistencies. Now, children who may have aspiration to thin liquids may not be willing to take in thin liquids, would be more willing to take in thicker liquids. So that is something which needs to be understood. Children with heart diseases cannot keep on having meals for a very long time. So initially, in spite of taking in enthusiastically, they lose interest a little way through the meal. So that is, again, changes during the course of a meal is something that needs to be evaluated. One of the elements of a good feeding is the interaction with the feeder. So the child's interaction with the feeder and whether there's any variation by the time of the day or with the feeder is something that needs to be kept in mind. The posture that the child adopts during feeding, and finally, very importantly, whether the child encounters any breathing difficulty, obvious cyanotic episodes during feeding. These are some things or choking, these are some things which need to be taken into account. Again, assessing infants can be very tricky, especially non-instrumental. These are some of the scales which are there. The NOMAS is a 28-point scale for both jaw movements and tongue movements. I won't go into the details of it. The SAIB is for term infants, their attachment to the areola, their suck, how many sucks per swallow. Again, preterm infant breastfeeding behavior is also something similar. It's just for preterm infants. And NNS is non-nutritive sucking. You see, children, non-nutritive sucking is when they are taking in or when they are sucking even when there is no milk. So sucking on a pacifier, sucking on their own fingers. There should be adequate non-nutritive sucking to ensure that this is one of the demarcators that the child is ready for swallowing. So non-nutritive sucking is something that needs to be looked for. This is a chart that I picked out of Johan Arvidsson's work, which primarily tests the functions of the cranial nerves. I won't go into a lot of details of it. You can see each of the cranial nerves, the stimulus that requires from that cranial nerve and the response that you expect from it, and the deficit in the response. So I think I'll just go ahead. A quick recount of the phases of swallowing. Now, the oral phase is divided into the oral preparatory and the oral transport phase. What happens in the oral preparatory phase is that the base of tongue moves up, the palate and the base of tongue come in contact, and the food stays in the anterior part of the mouth. In the oral transit phase, just the opposite occurs. The anterior tongue moves up, pushing the food to the back part of the tongue, and when the food comes to the base of tongue, that initiates the pharyngeal phase. Now, that's a complex set of events which occur, which finally result in the food being pushed into the upper esophageal sphincter, which begins off the esophageal phase. Now, when do we do an instrumental evaluation? You see, you do an instrumental evaluation when you feel that there's a risk of aspiration in the child, when you can obviously see that there's an incoordination of the sucking, swallowing, and breathing patterns. You suspect that the pharyngeal or esophageal phases, not only in older children but even in younger children, are affected. You realize that there's a wet voice quality, and finally when you feel that there's a laryngeal or pharyngeal involvement. Now, these are the three instruments that are present for evaluating a child for his swallowing ability: video fluoroscopy, the fiber optic endoscopic evaluation of swallowing, and ultrasound. Ultrasound is basically when you give the child milk feeds and then detect the milk on an ultrasonography traveling from the oral cavity into the esophagus. It's not something that I have used, but then it's noted in literature. I'll be talking about fees in pediatrics. So, the advantages that fees has is you can identify the structures that are involved in swallowing, their movements. Again, you can examine the child by giving the child food or liquid, which everyday food or liquid, rather than giving them some radio opaque material. The child can hold any position which he or she is comfortable with. Again, one great advantage is for very young children, you can examine the child while breastfeeding the child. And I've gone through 3 papers, one by the pioneers of fees themselves. So the pioneers have not mentioned a lower cutoff age limit for fees. Another paper has mentioned that doing a fees in children less than 6 to 8 years of age may not be very fruitful. And the last paper has mentioned that doing fees even in preterm infants is possible and can be quite educating. So it's for on my own part, I do fees for quite young children, 1 to 3 months of age, and it gives quite a bit of information. This is something which is conventionally taught. Oral and esophageal phases of the swallow are not very well examined on a fees examination. Now, doing a fees examination in a child is it's a pretty daunting task. The children are not very willing participants. You can see the fear on the child's face quite obviously. There are methods to calm the children. Sucrose solutions tend to not only calm the children, pacify the children, but also tends to initiate swallow. It's been shown to initiate swallow better. So sucrose solutions. Visual distraction strategies, as I think Thiru was showing the day before yesterday, when you hold a mobile for the child and then you do an endoscopy. Medical play therapy is when you teach older children that this is what is happening through play, and non-nutritive sucking is something we just taught, and breastfeeding. Now this is a video by our fellows who, this was actually done for video laryngoscopy, but then the concept is quite the same. This is how we would like to do a fees examination in children. Having said that, one size does not fit all. So in some children, the position may have to be different. Lying on the mother's lap, a little upright. Yeah, so now this is the part wherein probably giving a visual distraction is helpful and the child stops crying and you can feed the child. Anyway, moving on. This is the armamentarium. For very small children, I would prefer to use this scope on the right, that is 2.7 millimeter, and for this is around 3.7 millimeter with a tip diameter slightly larger. So for older children, this is what I would use. Now, this is how a normal fees examination would appear. You'll see the child making continuous swallow movements, and then the food appears on the base of tongue. And then it disappears from your view in just after a whiteout. So this is how a normal swallow would appear on a fees examination. Yeah, food dyes. You get it on all stores. Now, what are the abnormal findings that you see? So one is, of course, loss of food or liquid through mouth, that is anterior leakage. This is usually because of a poor lip seal. Again, material is pushed into the anterior or lateral sulci. Anterior sulci is usually because there are poor tongue movements or there are poor lip movements. Lateral sulci because of poor buccal movements. The material is pushed out with tongue is usually because there are tongue movements have not been developed very well in the child. Limited chewing is because of poor jaw movements. And if there are more sucks per swallow, the swallowing efficiency or the swallowing mechanism has not developed very well. So if there are more than 2 or 3 sucks per swallow, that is, the child's not very well developed for the swallowing mechanism. Again, in the transit phase, if there are searching tongue movements, that signifies tongue apraxia. If the material remains on the tongue or the hard palate, it's usually because there are poor tongue movements or the propulsion movement of the tongue is not very well. Then, of course, there is incomplete tongue palatal contact. If this is posteriorly, that could be because the base of tongue is not moving very well. If it's anteriorly, again, the anterior tongue is not moving very well. And if the oral phase all in all takes more than 2 or 3 seconds, rather 3 seconds, that is when you would label it as a delayed oral transit.
We are slightly behind time.
Oh, sorry. I'll just. It's not completely true that you can't do an endoscopic examination of the oral phase. You can actually introduce the scope through the nose, go in posterior to the soft palate, and then visualize a retrograde oral cavity. What you can see by this is the glossopalatal contact, movements of the tongue up to a certain extent before you encounter a whiteout. You can also see residues or stasis of food post swallow in the oral cavity. The pharyngeal phase is initiation issues. I'll just come to. These are there are four main problems that you encounter during a pharyngeal phase: spillage, residues. Residues can be in the vallicula or in the piriform fossa. Penetration, which means movement of the food into the laryngeal vestibule without crossing the vocal cords, and aspiration, wherein the food crosses beyond the vocal cords. This is the penetration aspiration scale. What is marked in red is penetration. What is marked below that is aspiration. Now, why I have brought this up is, in children sometimes demarcating aspiration may be a bit of an issue on a fees examination. So there's this study out here which has showed that deep penetration means that the penetrated material is nearly on the vocal cords or just above it. 31% of children have shown deep laryngeal penetration, but then 80% of deep laryngeal penetration children tend to have aspiration. So deep laryngeal penetration is a red flag, even if you have not seen aspiration. Swallow reflex initiation, as I was just mentioning, this study has classified swallow reflex initiation based on when it starts. So if it's normal when it starts on the base of tongue, if it's initiates when it's in the mid pharynx vallicula after a brief hesitation, it's mild, and severe would be when it's in the lower pharynx after prolonged pooling. The food pools up in the piriform fossa, and then there's an absent swallow reflex, is a profound swallowing or profound reflex problem. Now this is something which. So this is a child with a laryngeal cleft. You will notice that the child has a mild reflex initiation difficulty. When the food arrives on the base of tongue, it's just after mild hesitation that the child swallows. Additionally, you don't see a lot of aspiration which you might expect with a child with laryngeal cleft. The problem is residues. Even after swallow, you'll realize that the child is having a lot of residues in the pharynx, especially in the piriform fossa. So the residues are classified by something called a Yale residue scale. We'll let it be. Esophageal phase, the problems are slow bolus passage through the upper esophageal sphincter, residues in the upper esophageal sphincter, and retrograde bolus movement, whereas the lower esophageal sphincter, and then it comes up again. So there are pathologies associated with each of these. We'll not get into this again. It's not completely true that you can't evaluate the esophageal phase on an endoscopic examination. You do something called guided observation of swallowing in the esophagus, wherein you can advance the scope after the child has swallowed through one of the piriform fossa, and see the movement of the food in the esophagus as it travels down to the lower esophageal sphincter. There it is, we are inside the esophagus. Yeah, I think I'll just move along. I kept this video because this is laryngomalacia, and more importantly, it's a fees being done in a breastfeeding child. This is otherwise normal. There's a little delayed reflex initiation, but otherwise normal. You just notice the swallow starts after the food has reached the piriform fossa. Yeah, but then that can be acceptable with liquids up to a certain extent. You can also evaluate how many sucks and how many swallows go along in the same video. Yeah, that's that.
So we'll be left with very little time for the panel.
So I'm done. So intervention of the primary problem is a must. Airway safety, of course, has to be ensured. changing textures or consistencies of the food, increasing caloric density, especially in children with heart diseases, wherein you can't give them food for a very long time. So give them calorie intense food, small feeds, and postural changes. Now all of these have a lot of acceptance by the caregivers. The problem starts when you mention about nasogastric or gastrostomy tubes. That is a point of resistance with the caregivers. These are three studies. One is about alteration of infant position, which improves in laryngomalacia, which improves the swallow. The second is changing in textures. This is a beautiful study of just 3 children, but how changing in textures improve packing, that is retention in the oral cavity, and finally improvement of nutrition with NGT or GTs. Thank you for your patience hearing.
Thank you, Dr. Nilanjan.